Good morning. I'm Dr. Neil Noto-Roberto. I'm in a multi-specialty practice in Louisiana. Today my discussion will be about the functional analysis of the retina, what we consider to be the missing link in the evaluation and management of retinal disease. A quote that I had used approximately 2 years ago when we were evolving with macular functional testing, as well as understanding the real potential value in the diagnosis and management of macular disease, was that I had specified in an interview that macular function testing offers a highly specific method of identifying the true visual function of a patient's retina, which may otherwise be missed if only conventional methods are used. This really dovetails with what Dr. Alan Bird had mentioned on Friday at the Retina subspecialty meeting, where we really need at this point, with the treatments that are evolving, something more granular, something more comprehensive to evaluate macular function. We'll go over that in just a moment. So when we're evaluating retinal patients, we have a plethora of instruments that can measure anatomy, really elegant instrumentation. Biomicroscopies come a long way with better optics, advanced coatings, and better illumination. Optical coherence tomography, which didn't exist almost a half a decade ago, has advanced tremendously from time domain to spectral domain, giving you exquisite anatomic detail. Fluorescein angiography going from film to digital, then of course being enhanced with noise reduction and software, and autofluorescence. And these are fantastic anatomical instruments that can reveal anatomic changes for you. But what do we have functionally today? We have visual acuity, something that has relatively been unchanged for almost a century, and by no means can give you enough detail to assess function of the macula in an area, in an arena where changes are measured on a more microscopic level, on a more granular level, if you may. So is there a better way to assess visual function? Well, macular function testing. Again, Dr. Alan Bird at the meeting mentioned a variety of functional testing that could be used, but what really can meet the criteria for us to use as clinicians, that is compact, small, not only relegated to the research institutions, FDA approved, affordable, reimbursable. Well, macular function testing meets all those criteria. Not only does it overlay a high resolution image with the functional data, but allows you to pinpoint areas of pathology easily. Quantifying the quality of vision with using several metrics, which are important, as you'll see in my case studies. Average threshold over a larger area, threshold sensitivity in specific areas, and of course fixation, stability, and location. Things that two metrics that you're not really thinking about as a clinician until it's being presented to you, and then you can use that in the evaluation of the patient's progress. So what instrument is available today that really does that quickly, effectively? Well, the MAIA happens to be one of the premier instruments to do this. It's affordable. It has the lowest learning curve. It's integrated very well in a variety of practices, we'll see. Macular function testing really, besides giving you granular data at the specific points in the macula, enables you to qualify that data by comparing threshold data with age-adjusted normative values and giving you a very clean reading very quickly, giving you a patient's average threshold and fixation as being normal, suspect, abnormal. So you can quickly see this report when you're with the patient and judge very quickly whether you need to dive deeper into that data and look at the actual values, which are also presented in a linear format that's easy to read. So the instrument actually, the MAIA offers you two different ways to acquire this data. And the two different ways actually work really well depending upon the type of practice you have or how you want to implement the use of the instrument. So the FAST test, which measures 36 points over a 10-degree area, is really designed as a wellness test. It's fast, it takes about 2.5 minutes, it's under 3 minutes without any doubt. There's no insurance reimbursement because of the type of test it is, but if you may, you can see how this could be used in certain practices as a wellness test, as a value-added service, where patients who are being tracked or monitored for their annual or maybe their biannual examination, they opt for this test to get a better assessment of what their vision really is. Or you could use it like we do in one of our satellites where we know we have patients with pathology, but do we really want to run the full extended test, the expert test, and not know whether that data is pertinent or not, put the patient through that and not really get reimbursed. So the FAST test allows us to look at patients who have a family history of AMD that may need further evaluation. Patients over the age of 45 are at a higher linear risk for the 4th leading cause of blindness in the world. cataracts, glaucoma, AMD, and diabetes. Unexplained visual problems. Patients with subjective complaints, though their visual acuity, remember that core standard we have, is relatively normal. Diabetics, okay, where we don't have the ability to look at our non-proliferative diabetic retinopathy population in a very detailed manner to give feedback to the primary care doctor whether that hemoglobin A1C is well, whether there's underlying nephropathy or neuropathy or retinopathy that's undetected by our current functional testing methods. And in pre-op and post-op cataract patients, which I'm about to show you, it does play a part in. The FAST test gives you very quick and easy to read data in terms of fixation and macular integrity. The nice thing about this is this helps a technician, it helps you very quickly know whether you should order this test, all right? So this test can be performed when the patient is getting an evaluation for a certain macular pathology. Because in this country, you need to order a test to be able to have the reimbursement and to meet the auditing criteria for CMS. So using the FAST test allows you to see if there's anything that probably needs further or extensive evaluation. So we move on to the expert test where it's full threshold. It's designed as a medical test, has CPT code associated with it, so it's reimbursable. And not only does it give you the severity of the scotoma in a certain area, but also the extent of the visual loss, again, on a granular level. And that's the static data. Not only does it give you static data, but it also gives you dynamic data. This dynamic data will help you track changes, the evolution, the progression, regression, depending upon the treatment modalities you're using for your macular pathology. And the data is presented very well, easy to read with specific points able to be analyzed with that overlay over the anatomy, so you can find the areas that you're looking at very quickly. Not only that, but there's toggle switches that you can see here that allow you to toggle on and off these data points so you're not overloaded with data that you may not need, such as showing the preferred retinal locus or maybe removing the fixation point so you're just showing the stimuli. The follow-up test again goes with the dynamic nature of this test. The dynamic nature of the test allows for exact quantification and qualification because not only the data is repeated, but it's repeated in a method using eye tracking software, so the data is repeated in an exact manner, in the exact location, so it's verifiable. And again, the follow-up test is considered a part of the extended test, so it's CPT reimbursable. And then the software allows you to not have to flip through pages of data to look for progression or regression. It presents it in such a way so you can see dynamic data in a linear format for easy access and really analysis. So in our clinic, the MAIA really is an integral part because almost every patient coming through has some type of maculopathy, from ischemic to edematous to neovascular. So we utilize the expert test and we utilize the follow-up test. The expert tests, of course, help us determine functionality, and we will see case reports on how we use that specifically. But more importantly, the follow-up test helps guide our treatment plans. So let's go over some case studies. So this is the first case study here. There's a patient with significant CSR-induced vision loss, metamorphopsia. Patient, when a patient comes in with CSR, we always assess the patient and give them their treatment options. We give them what the standard of care is, and then we give them what other alternative treatments are. We try to educate them because in today's world our patients are internet savvy, they get a lot of data, and if we're not presenting the data to them ahead of time, they may feel that we're not aware or we're not capable of delivering any modality possible. So this patient, we asked him to wait 3 months, but unfortunately he was a crane operator, so he needed stereopsis to be able to operate the crane. He was at risk of losing his job. He had a very short time period to get better. After 2 months, we decided to use micropulse laser. This was the preoperative anatomic findings here. You can see the large area of damage. And postoperatively, the patient improved to 20/40. Still below baseline. We had some old data on the patient. He was 20/20 beforehand. Patient was upset. Patient was upset. Well, first I should quantify that. The patient was able to return as a crane operator. He was able to regain stereopsis, enough stereopsis to continue his job. Yet he was upset because he had expected his vision to return not only to normal, but the quality of his vision to return to normal. Well, the MAIA really helped us to explain to the patient and the patient's family that it could have been a very difficult situation for us, that the preoperative and postoperative sensitivities had increased by almost twofold. A significant increase in sensitivity, but as you can see here, there is a decreased threshold to help to help illustrate to the patient why these subjective complaints, why the vision was not as sharp or a little bit more hazy than it should be. He was able to understand by the visualization of the data, and the family was able to understand why there was not a return to what he considered quote-unquote normal. We were able to also prove to the patient that postoperatively that the patient's postoperative fixation was much more stable as well. And in the end, the MAIA helped us, like I said, illustrate these points very well. And this patient and the patient's family actually became one of our biggest proponents after we were able to educate them very well. Next patient, we have a case of a Vitelliform dystrophy and a visually significant cataract. Patient presents as a consult for a candidate for cataract surgery from the general ophthalmologist. There were simultaneous pathologies of a cataract and Vitelliform dystrophy. The general ophthalmologist was concerned about setting the expectations and wanting to know if expectations for the patient and wanting to know if the surgery would make a difference for the patient. The GO also wanted to track pre- and post-operative results to determine the impact of cataract extraction on this patient. So here's the patient's fundoscopic photos. You can see a large central foveal lipofuscin deposits, stage 5 of right eye, stage 2 in the left eye. No ectopic lesions noted, red-free image, really unremarkable. Fluorescein angiography was typical without evidence of cortical neovascularization. You can see anatomically that over time, over a large gradient of time from 2009 to late 2010, the patient showed excellent stability of the retinal pigment epithelium in both eyes. There was some mild retinal pigment epithelial atrophy, some migration, but nothing significant. So here you can see a decline in the left eye specifically over 11 months associated with decreased sensitivity. You can see the sensitivity decreased right here, average threshold decreasing as well. Oh, note the visual acuities as well. And if you track the visual acuities, you're going to note that, that we have noted in clinic in practice that the threshold measurements are more sensitive over time than acuity measurements. It seems that acuity tends to trail threshold measurements. You can see after surgery how the patient improved, vision improved, sensitivity improved as well. Again, the MAIA helped us initially to look at the data, and we knew that through the sensitivity data, as we knew that through looking at the fixation, that the patient's macular status was overall pretty stable, and that the depression in threshold was mostly due to the cataract. And we were able to prove that afterwards, of course, after cataract extraction. The patient's vision did improve significantly. The thresholds did improve while the fixation initially allowed us to tell the general ophthalmologist that he should be successful with surgery and he should move on. It was not a macular pathologic issue. The next case was another consult. The patient had simultaneous multifocal intraocular lens implant with a history of AMD. The patient had subjective complaints after a successful cataract surgery. They had a history of stage 1 dry AMD. The patient was followed by us for high-risk conversion to wet AMD due to genetic testing. You can see here the patient with mild dry AMD changes and pretty good acuity early. You can see here the patient had mild dry AMD changes and pretty good acuity early on. Very small amount of RPE changes. Here, prior to cataract surgery, the patient had good thresholds. You can see thresholds on both before cataract surgery was still within normal limits, not significantly depressed at all. So the patient underwent cataract surgery in the right eye. You can see that the patient's threshold remained very well. You can also see that and it's not listed there, but the patient did very well with good vision. So good vision and thresholds in the right eye, while the left eye had minimally depressed threshold, and fixation was good. So post-cataract, let me go back. Interesting to note, fixation here again, very tight. Okay, this eye did not have cataract surgery yet, did not have the multifocal implant. Depressed thresholds, but a very good fixation. This is the eye with the multifocal implant. Thresholds were elevated, but fixation was less stable. We see the same thing here. Postoperatively, intraocular lens implant, thresholds was incomplete on this test, but the main feature here is again fixation. Fixation was depressed. Anatomy, we thought that maybe there was some macular dysfunction of the RPE, maybe some subretinal pathology. There was none. Maybe a little bit increase in choroidal thickness, but nothing with the RPE, inner or outer retinal nerve layer. Sorry. And so we decided that we did not see any anatomic changes in the macula. The multifocal intraocular lens implant was seen as the etiology for the fixation changes, and that were related to the patient's subjective complaints of suboptimal vision. Despite other metrics looking good, the patient was on acuity measurements was 20/20. Threshold measurements were normal. Anatomic measurements all looked normal. And yet we could see using the MAIA why the patient was having these subjective difficulties. And once we were able to see that, the general ophthalmologist felt that the lens implant, and agreed with us, was because it was of a diffractive type of technology, was the cause of this problem. Did the lens exchange in one eye and is doing much better. He had called me actually a week ago before I was able to update these slides. Patient's subjective complaint at one eye is gone. Vision still 20/20, has a normal monofocal implant and much happier. So we're able to help elucidate for the general ophthalmologist using the MAIA that it was not his dry AMD, which everybody would like to blame, but we brought back the quality of the patient's life by improving their vision, by delineating and really specifying what their problem was. Another type of patient we use the MAIA in is diabetic retinopathy. So we're involved in we're very fortunate, we're involved in a diabetic retinopathy trial. So the pharmaceutical company came to us looking for some advice on functional measurements of the macula. They had already, they were already relegated to using fluorescein angiography, fundus photos, an OCT, and that's really a no-brainer. But they really wanted to assess small, and this is probably the most important case, they wanted to assess small changes on a very small level, granular level, of this drug's effect on non-proliferative diabetic retinopathy. The purpose of this drug is to reverse non-proliferative diabetic retinopathy changes on a microvascular level. Visual acuity in no way, is going to be able to grade this. These patients were already 20/20, 20/25. What more? How would we reach statistical significance on that metric? It would be almost virtually impossible. We had shown them some MAIA studies, some preliminary studies. They decided to use the MAIA for tracking functional changes in the macular region. It was beautiful, actually. Fluorescein angiography, typically what you see with microaneurysms, nothing no neovascularization. You can see stable central foveal anatomy, nothing going on here. This is one patient over a 5 to 6 month period. And here we can see the patient's MAIA test in the right and left eye. This is in February. This was their baseline MAIA. We're able to look at their sensitivities again. This was baseline before the drug was given. This was a stage 1 mild non-proliferative diabetic retinopathy patient. And this is July. After a 5-month period, the drug had improved the patient's thresholds in the macula with an increase in macular sensitivity. The series of patients we ran, which were 12 patients, well, 10 after 2 had dropped out due to non-compliance, we were able to have enough to show statistical significant difference and an improvement in thresholds based upon the MAIA. There was no other way this drug could have been tested to show these changes. And again, this goes with what Dr. Bird was talking about, that these new developments coming for dry AMD, these new developments that are coming in for wet AMD, but more importantly dry AMD and even diabetic retinopathy, as clinicians, we are not going to be able to convince a patient to undergo an intravitreal injection when they have 20/25 vision, unless we show them metrics that they are actually improving. And the only way we can do this is by having more refined data, and this is how we're doing it. This just summarizes what I just said. So next case, branch retinal vein occlusion post micropulse laser. So this patient had previous treatments on and off for recurrent edema from ischemic-induced edema from a BRVO. Patient, after so many injections over the years, wished an alternative method of treatment due to some relative contraindications that developed. So the patient had chosen micropulse laser. Here you can see the effects of micropulse laser. The vision had come back to about 20/80. Well, let's look at the MAIA. This MAIA does not correlate with this anatomic change. These MAIAs are taken months before that edema had occurred. This was the baseline MAIA approximately 6 months before that that macular edema occurred. You can see the patient had fair vision and pretty good sensitivities all the way around and good fixation. After treatment was induced and we remeasured the patient, you can see here that we were able to keep the patient's sensitivity statistically the same, that the actual granular points here had not changed before and after, after treatments. So why is this data important? You're saying, okay, well, the patient did better, anatomy looks good, what's the big deal? Okay, this happens to be one of the better patients. A lot of our patients, actually, they start losing sensitivity in certain areas after retreatments. The MAIA helps us set patients' expectations of what to expect. When a patient does not do well with a BRVO for whatever reason, they have recurrent ischemia with recurrent edema, these patients are under the belief that every time they get treated, they're going to come back to where they were. That's not really always the case. Again, the MAIA gives us data that precedes visual acuity loss. So we're able to see after each treatment if there's any loss of foveal or macular sensitivity. If that's the case, despite the vision coming back to what their baseline was or is at that time, we can tell the patient, look, there is retinal damage on a microscopic level. There is ischemic damage that's occurring. If this continues to happen, you're going to start losing vision. You're actually going to start losing your acuity. This helps guide us to maybe using other treatments, maybe non-destructive treatments or alternative treatments. And I think this is one of the last cases. This was a case of central subfoveal drusen. This is a patient referred by the general ophthalmologist before LASIK surgery. The GO wanted to set the patient's expectations appropriately due to macular pathology. They felt that there may be some asymmetry due to subfoveal pathology and that possibly that the surgery would not significantly improve them. So we also noted over time there was an increase in the increase in RPEDs, retinal pigment epithelial detachments, and we need a more granular or detailed assessment of this change on the patient's function. So you can see here, I think, very faint scattered drusen throughout. You can see them better on fluorescein angiography. You see them, they absorb the dye, you see them hyperfluoresce. You can see subretinal RPE elevations due to these drusen. And what was important about that was that there was some juxtafoveal and foveal involvement, as you see there, in the right eye and juxtafoveal in the left eye. So what we did here, we ran a MAIA test on both the right and left eye, and we saw that for the most part, macular sensitivity over the entire area, but specifically in the area where the patient's final acuity would be, was relatively normal despite these RPE detachments. And you can see here that even after surgery, despite the increase in RPED, the threshold held steady and the overall sensitivity was unchanged. And the left eye also remained steady. Sensitivities, again, are remaining very stable. So we use that data. I'll go back to that real quickly here. So we use this data, again, to help evaluate changes in pathology and also the effects or sometimes non-effects our treatment have on a patient's treatment protocols for certain pathologies. Thank you very much.